And once that's up, I'm just going to go live here. We're just getting things going live here. Give us 1 second. And go live. Perfect. There we go. Well, hopefully you guys are already on the channel. Welcome to the first episode of Sperm Meets Egg. We're really excited to bring this to everybody. What we're trying to do is not just be an educational show, but really a chance for people to talk to doctors, talk to them about their cases or questions they have, and just really bring a lot of things to light. We have an assistant who's with us, Ari. She'll be popping in at times, telling people about questions that people are saying and getting everyone prepped who are going to be coming on. But we're really excited about this. And most of us, when we're in like class, there's a question someone asked, and we're all wondering the same thing, but everyone's afraid to ask it. So the nice thing about this show is people are going to ask those questions, and you're probably going to get them answered. But if you don't feel comfortable coming on, then just send us your questions, and we'll answer them as well. But we're really excited about this. Dr. Salem and I, this is something that we really are excited about. So if you're interested in this and you want to be a live person, make sure you go to the website spermmeetsegg.com. You can find the link and join. And we're going to be doing a lot more of these. This is just our first one. Anyways, let me let Dr. Salem introduce himself, and we'll go from there.
Yeah, thanks so much, Dr. Amos. I'm Dr. Salem. It's an absolute pleasure to be here, and such a pleasure to be part of the larger NDFC family, and very excited about the location launch in Scottsdale here very soon. So without any further ado, I'll let you take it away into our first Sperm Meets Egg.
Yeah, so one of the first things we just wanted to start with was talking about, what do we think is the most exciting innovation coming out? And so we just thought we'd start off just talking about that topic. I'll let you go first, Dr. Salem. We were just talking about before we even got live, and so I'll let him give his, and then I was just going to tell what I think some of the most exciting things coming out here.
Yeah, no, thanks. I mean, I got to say one of the greatest things about our field is that it's constantly innovating. And if you're a doctor who likes staying kind of ahead of the curve, there's always something right around the corner. But as I kind of think back about what's been the most exciting and kind of impactful innovation in our field, really in the last decade, I would say it has to be PGTA, and this opportunity to leverage genetic technology to really understand if the embryo is quote unquote kind of a normal embryo or not, so that every time that we do an embryo transfer, we can do it in a very sure-footed way. We're very confident. If we're putting an embryo in there, most of those patients are going to come away with a baby on the other end. And that's just something that's remarkable. And I think that's just completely changed the way many of us look at our field. And I think the other part of it that's really, really cool is it gives us the option to choose to transfer just one embryo if that's something that the patient wants, to really minimize many of the risks associated with, let's call them triplets, or things that used to happen back in the day that really don't happen anymore because we're so targeted in how we're transferring embryos with PGTA. So hard for me to kind of ignore that one as the one that's been the most exciting in recent years. That's really changed the way we practice fertility medicine. But I don't know, what's yours? What do you think?
It's interesting when you were talking, that's the first thing I was thinking is not just how cool that is, but how much it's helped. I mean, I remember the days back when, like, even my wife and I went through IVF. We put back 2 embryos and our chances were at best 40%. And now you put back 1 embryo and you have a 60% chance of a live birth, just generally. And if you look at the pregnancy rates, you can see them all going up, in the SART data and then CDC. And so it really has changed the field a lot. It's allowed us, as you said, to be able to have, reduce multiples, and people can feel safe putting back 1 embryo. Whereas back in the day, like, no one put back 1 embryo. That was insane. You would have a 20% pregnancy rate. So it really is, I think, one of the things. And to touch on what you're saying and how important it is, I think one of the next innovations that we were talking about earlier is when we can do it without biopsy. So right now, obviously, doing a biopsy on the embryo has risk. Anything we do has risk. Even moving an embryo between dishes has a risk. But when you do a biopsy, we get worried about having a risk because you're taking cells away, right? So if someone took my arm away, I'd feel like, man, that really hurt me. And we think the same thing with embryos, but in reality, it actually doesn't hurt the embryo. Embryos, remember, split, and they, you get identical twins, and nothing happens to them. So it really isn't harmful. But the problem is that not everyone's trained as well. I mean, just like LeBron James is the best at basketball right now. Not everyone's as good at biopsies, and so different clinics might have different people who have different qualities at it, and it could hurt the embryos in some situations. I do believe that has a big impact. And so when we can eventually get to the point where we can do no biopsy at all and just take the fluid and the milieu that it's sitting in and can determine the same things, we'll have the same success rate with almost zero risk at all. And I think that's pretty exciting. So obviously there's a lot of, we talked about controversies and stuff that come with that and things, but anyways, we could go on, and you guys probably get bored out of your mind hearing what we think. So we're gonna bring up Ari. Ari is gonna be assisting us with everything, and and so I'm gonna bring her onto the stage here. And
Hi, everyone.
hi, Ari.
Hi. Welcome to our live Sperm Meets Egg. So we have some questions that was submitted today via through our social media platforms. So I'm just going to ask you guys these questions and get started. So one of the questions we have was from one of our patients via Clara. And they wanted to know, what are some realistic expectations that a male and a female or patients in their mid-30s regarding the success rates of fertility treatments? They wanted to know, how do these rates vary based on individual factors?
Yeah. Do you want me to take this one for a second?
Sure, go ahead.
Yeah.
Take it away. Yeah.
I'll take this one, and you take that. So I think this is a great question. I get this asked all the time. What's my chances? And I'll get that asked in the very first appointment. And I always tell them I can give them the generic answer, right? So what we know is when you're under 35, the chances are kind of the same across the board. But what changes those chances are going to be things like, do you have endometriosis? Is there a severe sperm problem? Is there a tubal disease? Those things that we're testing for is what then changes your diagnosis and then changes your chances. What we do know is as you get older, it gets harder and harder, and that's mainly on the female side. And that's because egg quality does change as you get older. Men also have some decrease in quality of their sperm. But in the end, when you're just generically thinking about it, IUIs for someone under 35, you're looking at around somewhere between about 12% to maybe as high as 22%, depending on how aggressive you're being. And then when it comes to someone like IVF, you're usually thinking at least 40% without doing any type of testing, to as high as 70% to 75% with a PGT tested embryo. But like I said, what your chances are going to be dependent on what you do with your doctor, what they find out. And so I don't know if you have anything to add to that, Dr. Salem.
Yeah, no, I love that. I mean, I just to kind of piggyback off of that, it's true. It's like, as fertility doctors, I think, people think we're like oracles. We can just kind of like look at you and just kind of, spray some dust or something, and we know what your percent chances are of getting pregnant. The reality is, I mean, we do a lot of testing to kind of uncover what some of your risk factors might be, or some other things, and just to kind of reflect back on your point, Dr. Amos, I mean, if somebody's coming through and they're, less than 35 and they only have tubal factor, then it's a very, very, very high, chance of pregnancy. But if somebody's coming through and they have a very, very diminished ovarian reserve, a very low number of eggs, it might be a very different combination of things. And so the personalization of treatment is extremely important because of those differences between, where people are coming in at. And if that weren't the case, it would just be a one size fits all, which it absolutely isn't. So, yeah.
Well, Ari, I see we actually have a lot of people that are starting to come in, so we probably want to go to one of them. And I know the order of people coming in, so we'll let you start there.
Yeah. So if you have a question and you would like Dr. Salem and Dr. Amos to answer it, go ahead and put it in your private chat. You should see it on the side of your screen to the right-hand side. That's where you'll submit your questions. And also, if you want to be on camera and speak with them, also put that in the chat so I can bring you in.
I see. Let's just check with Candace there. Candace, are you ready to come on? No? Oh, yes? Okay.
Okay.
Well,
I'll
here,
add her to the
we'll
page.
get you on right now. There we go. I don't know if we can hear you right now. You might be on mute. I know we don't hear anything. Do you hear anything, Dr. Salem?
Not just yet.
Yeah. Here,
maybe.
How about we do this? We'll have RA work with you in the background. Let's see if we can get that fixed. I see your mic is not muted. It might just be something with a permission. So we're just gonna put it out, and then we're gonna go talk to someone else here. We're gonna talk to Teresa and Richard here. Hey, Teresa. Hey, Richard. How are you guys doing?
We're good. How are you?
Fantastic. You're technically the first couple ever to be on this show. So well, we're excited to have you here. What we're planning on doing tonight is just kind of, a discussion and see what questions you guys have for us, or maybe about your case or anything like that. So we'll let you kind of ask any questions you have for us right now.
I really don't have a question just yet.
Well, tell us about your case. Tell us about your guys' journey so far. And like I said, and we can kind of give you a little input of what we think, and people kind of see, how do we go through that? How does Dr. Salem and I take all that information and process it, if you feel comfortable, obviously.
Yeah. So Teresa has 3 children of her own, but she had her tubes tied and burned. And then when we got together, she knew I haven't had a baby of my own yet, so she knows that I wanted to conceive, or that I want to have a baby. So she was willing to try this process. We looked at other different avenues of the reversal, but having to pay that much money on a reversal and them not guaranteeing us any success. So then we got into the IVF idea, and I guess this is where we're at.
No, I mean, it was
sorry.
great that you guys opened up with the 35 and older versus the younger, because I mean, I am hitting 36 next month, so I'm like, oh, that is a concern of mine, and how my body is going to react to the injections and the whole process. So it was really cool that you guys opened up with at least hitting that age marker, which I guess a lot of us have concerns with.
They do. I mean, question for you, Dr. Salem. I know myself, I don't get too worried about when someone comes into my clinic and they're like 37. I'm not, even up at 38. I'm kind of like, yeah, this isn't going to be too much, too difficult. There are situations where people have poor ovarian reserve, but it's really after 38 when I start really getting nervous. That's when I start getting worried, because that's where you see the biggest fluctuation. What do you think? I just wondered if you agree with that.
Yeah, no, definitely. I mean, I think that historically, everybody was really, let's call it like freaked out by 35. But really what you see is like there's a little bit of a gradual decline in ovarian reserve, egg numbers, that kind of a thing. But fortunately, it's 2024. And we have all these, let's call them fancy tools and technology that helps us overcome some of these things. Now, obviously, what happens is the efficiency of our technologies do decrease. I mean, even the very best technology in the world will decrease as the age is increasing here. But I agree with you. I mean, I'm not too worried about 35 or 36 or 37 or 38. And we have so much success even among young women in their early 40s. So now it doesn't mean that it's quite as easy, but still.
Yeah, it's definitely, I would tell anyone, yes, at 35, that's the point where you have to say, I need to start thinking about these things. That's for sure. But when people come in, they go, I don't know if I'm gonna be able to get pregnant. I'm 35. I'm like, whoa. You're young. I'll get too worried. It's interesting because we get people coming in where they're 44 and they're like, okay, now I'm ready. And you're like, oh, I wish I would have seen you a decade ago. So like I said, 35 scares women because I think that's a number been pushed in everyone's head. And it is a good measure to know you need to be thinking about something at that point. But again, I wouldn't be too worried. I want to just talk about the topic of, Richard, this is actually very common. I mean, a lot of people have their tubes tied. I hear stories all the time of women not even wanting their tubes tied and made a decision in that moment and thought it was the right decision. And as you said, sometimes doctors burn them and there's not even ability for a reversal. But I think that's a great question about a reversal, because one of the things that has happened when you talk about a shift in medicine is there was a time reversals was kind of the main thing you did, because doing IVF, was so expensive and it really didn't have a high rate. In the beginning, I talked about my wife and I, 2 embryos, 40% best chance, but it's changed now. And what's happened is fewer and fewer people are doing reversals. And when you don't do something, you kind of lose a skill a little bit. I mean, I haven't even done a reversal in so many years. And so what's changing now is really everything is being pushed towards IVF in that situation, or some type of treatment, even like IVC, where you're bypassing the tubes. But it's something that's coming up a lot, and we see a lot of it. And when people always ask us, what should I do? My answer, I tell them, is this: if you're just wanting 1 pregnancy or 2, you do IVF. Now, if you're someone who's saying, hey, I want six kids, well, that's gonna be very expensive. You're probably better off trying to get a reversal. And the important part here is find someone who does a lot of them. Do not just go to someone who's just, hasn't done one in a long time, in 5 years. You're probably not going to have success. So Dr. So I'll let you answer that in your view.
Yeah, no, absolutely. I couldn't agree more with that. I mean, I think the big differentiator here, to go back to it, is this idea of what is your kind of future plans for building your family. And if your plan is to have 1 or 2 children, and especially if you're maybe a little bit older, like above 35, then IVF is going to present a much more efficient way of doing it. And you're also going to, by the way, avoid surgery, which is a kind of a big deal. The flip side of it, there's a small group of women, of couples who may say, well, hey, I want to have many children and I have many reproductive years ahead of me, and let's give it a go. Let's try the tubal reversal. And by the way, tubal reversal, 50% of the time, it closes back up. It blocks back up right after the surgery. So you end up having to go to IVF anyway. So, it's a little bit of a give and take.
Well, any questions you have for us? Otherwise, thank you so much. I mean, like I said, and we really wish you guys the best of luck. And honestly, at your age and everything, the chances are going to be pretty good. So.
Oh, thank you guys so much.
Appreciate it.
No problem, you guys. Well, it's a pleasure talking to you, and I hope you guys have a great night. And please check out, like I said, the show in the future. It might answer a lot of questions for you. I'm sure you helped a lot of people.
All right. Thank you.
Thank you.
Hey, Ari, who we have next to talk to?
Let's see. We have some people that are trying to get into the studio. So let's see. I have
try-
another question.
And I know Candace is still there too, so I feel bad.
Yeah.
Like if we could give Candace another shot here.
Yeah, let's
She's like shaking down. You don't have to.
let's see. Hold on. Let me.
You want me to
Okay.
click it?
Is this Mutters? Do you guys want to ask a question?
Oh.
Let me ask her.
Yeah. Well, I'm assuming if they're here, they probably want to. So I'll put them on the stage right here.
Okay.
There we go. Like I said, otherwise I wouldn't. I don't think they'd be on here. Let me just. I'll get you ready. Hey guys, how are you doing?
Good.
When I first
All right.
saw your name and said Mutters, I thought, did it say murders? I was like, that's obviously very scary. I was like,
Everybody does that.
well, you know how our brains work. We look at something fast and like, oh, the murders. That's not good.
We think we ought to just change it to it. That way people are right.
Well, Well, I mean, depending on what you do, it might be worth it, if you're hitman
Yeah,
or something
that's true.
like that. Well, anyways, Dr. Sam and I were here just, listening to people. I don't know if you guys are coming in with a question, or like the last person just want to tell us a little bit about your case or tell us about your journey. And we would love to let other people know about that. And we can probably answer some of the questions for you guys if you'd like to go ahead.
Yeah, I kind of had a question. I mean, so our doctor is Dr. Johnson, and I kind of asked him, but something I'm still just curious about. So in our case, I am missing my vas deferens tubes. My wife Alicia, she's fine. Every test with her, she's checked out normal. But so my question is, I know the chances of twins double, like through the IVF process, and as opposed to the traditional way. But if you implant 2 eggs at once, does it also then more increase your chances for twins? Is that a wise thing to do or an unwise thing?
Yeah. This is a great question, and again, one that comes up all the time. It relates back to a little bit about how we kind of kicked off this session today. But historically, right, like in the past, now we're talking about IVF, and what we're talking about, I imagine, is putting in 2 embryos at once versus putting in 1 embryo.
Yeah.
So it used to be that when we put in 2 embryos at once, you were doing it because you were trying to get a higher chance of a pregnancy altogether. And there was always this risk in the background of having twins. But what's happened over time is we've gotten really good. And the embryos are individually getting better and better at sticking and leading to a baby. So some studies will show us now, for example, that if you were to put in 2 genetically normal embryos, this comes from a study that they kind of looked at this in a hidden way, we'll call it, that your risk of twins could be as high as 30 to 40% if you put in 2 genetically. So in an effort to really reduce that risk to 1% or less, really, you just put in 1 genetically tested embryo. And this is probably one of the most sure-footed ways that we can help couples avoid, having twins. And not that having twins is bad; it's amazing, and it's and Dr. Amos could probably speak a lot better to that point. But it's that obstetrically, when you are pregnant, having twins is going to introduce much more risk along the way. And we're trying to help avoid risk as much as possible. But Dr. Amos, he's really kind of an expert in his own way on this one. So I'm going to let him chime in here.
Yeah, so a couple of things. I mean, I love twins. And I think one thing that it's hard for a lot of doctors right now is because there's a push right now to, 1 baby is the safest. There's no question about it. There's no situation where 2 embryos are safer than 1. Never. But when you can't get pregnant and you don't know if you're ever gonna have another baby, having 2 is a blessing. You're like, man, I have a built-in, friend for them, a sibling, and no matter what, for the rest of your life, hey, I have 2 kids. Like, I know if I pass away, they have a sibling with them. And then that's the thing that why I think we all who have infertility desire so much twins. And there's even like I do a podcast, and one of them I talk about how many embryos to put back. And one of the things I talk about is that when you only have 2 embryos, sometimes you actually have a higher chance of putting back 1 at a time than putting both back at a time, even though truly putting both at the same time gives you a higher chance of 1 taking at that moment. But if they both take, if anything happens to the other embryo and it causes bleeding, you could lose the other one. So you have twice the chances of problems. Yeah. I wanted to touch base on the things talked about. So we call it CBAVD, which is congenital absence of the vas deferens. And interesting enough, I'm not sure if you're aware of this, you could be missing a kidney too. So one of the things that happens is a development of the urogenital ridge in embryology. And when it was forming, it didn't form correctly. And so basically, as you said, technically the testicle is not connected to the penis with this vas deferens. And, most people would think like, oh, it's, you would probably know. You would have no idea that you have this. I mean, everything's the same. What you ejaculate's the same, because that comes from the prostate and the seminal vesicles. The amount of sperm adds nothing to volume. So you would have no way of knowing this. It's just like, I didn't know I had bad sperm until I got semen now. So I was like, oh, okay. I thought everything was working fine. What's really great though, is, this is where I'm so thankful that in the 1990s, when they came up with a thing called ICSI. ICSI is where they're able to inject the sperm into the egg. And so when that came around, it allowed people like myself and people like you to be able to have success. And I would even say to you, I don't never look at it as like, oh, everything's fine with her, it's all me. It's a couple thing, right? It's together. I mean, so I don't look at that, but listen, it's, you guys are one now and it's your guys' problem. But the good thing is you're in a really good position, because that is one of the highest prognosis type of patients, and usually, as you probably know, there'll be a procedure to get the sperm extracted, and then you make embryos, and usually things go fine. But, one of the reasons I say it's together is because there could be something wrong. You may not know it. Remember, IVF is a test. It's not just a treatment. There are times we're like, oh, it's just a guy problem, it's just this. And then all of a sudden we go through and we go, oh my goodness, these embryos don't look good. And we learn something. So that's why I say I always look at it as, hey, it's a team effort. We're both going into it. But I just thought maybe a lot of people don't know what that is, when they hear that. And so, like I said, check your kidney out someday. You could be actually missing a kidney.
I might have to. Sounds like it.
You can't be missing both. That would be impossible. But missing one.
Yeah. Okay, good to know.
That's Sam. Anything you have to answer? I mean, like I said, I thought you said everything great, so I didn't have anything to add to that, but just added those other couple things. So,
yeah, no, that's. I mean, do we feel like we answered that question, guys, or is there anything else that you wanted to touch on there?
No, I think that's it. It was a good answer. Thank you.
Yeah, absolutely. Good luck. Wishing you all the best, and hopefully a pregnancy around the corner here.
Thank you. We hope so too.
Thank you.
Well, I look forward to seeing you guys and seeing you guys pregnant.
Thanks.
It's interesting. I hear this a lot from people where they're always like, I'm worried about doing IVF because I'm going to get twins, or I don't want twins. And I have to explain to people that actually your highest risk for multiples is in IUIs, because you can't control the number of eggs. So if you got 3 eggs, you can get 3 babies, even though it's unlikely. Whereas IVF, it's actually the one area you can truly reduce it down to 1. Now, obviously, God can get involved and split the embryo, and then you got identical twins, but at least we don't get blamed for it then at that point.
Yeah.
Let's get Ari on here.
Right.
Hey, Ari. So I know we got another person here.
Allie is next. Are you ready, Allie? We're going to bring you to the stage.
We got thumbs up.
I'm ready.
Fantastic. Hey, Allie, how are you doing?
I'm good. Good to see you. Obviously, Dr. Amos is my doctor and my husband. But I think we've been in kind of a decision-making season of what are we going to do next. So we had a failed IVF transfer earlier this year, or I guess in the fall. And we just learned some unique things. I'm 28, but I have the eggs of like a 40-year-old woman. So we have that. I have PCOS. My husband's motility is really low. Well, not as high as they'd like it to be. And so I think we're just in this, like, is it worth doing that again? Like, do we look at other options? Is adoption the way to go? Like, how likely is this even to happen? I think we just want to be realistic. And I mean, I know we had a chance to talk, Dr. Amos, but it'd be cool to hear your thoughts, Dr. Salem, and then just if there's anything else you'd want to add. We're just trying to figure things out right now. So.
Yeah, let me start with this one, and Dr. Salem, I'm going to have you kind of give your view of that. I think one thing that's important to understand, when someone says your eggs are acting older, I think it's really important to understand that your eggs aren't actually older. So I will take any day 3 eggs from someone who's 28 over 12 eggs from someone who's 42. And when we say someone's eggs are acting older, we're just saying that when it comes to, numbers being made and how they're reacting, right? They just act different. But in the end, when you're younger, your chances are always better because the genetic part is not the same. When we talk about abnormal eggs being like DNA problems, when you were older, it's a high percentage. So even by 42, up to 85% of the eggs are going to be genetically abnormal. So when you're younger and someone says they're acting older, it's just important to always remember your DNA is probably better than anyone who's older. It's just there's certain things that are mimicking that we see in women who are older. So whether it's higher GV rates, whether it's not making it to blastulation, abnormal fragmentation, all those things. And what's good is you can make the adjustments to try to fix those. I personally, again, being someone who's been through fertility, I always remind people you can always do donor eggs or adoption, right? There's no limit on that. You can be 45, 48 and still do donor eggs. So to me, I say no, you do everything you can when you can. That's your window of opportunity. And remember, you can always do those other things. And I told you the same thing. No, you crazy talk, like not using your own eggs and stuff right now. But anyways, I'm gonna let Dr. Salem offer, because obviously you've heard my opinion, and then I might chime in after him, some of our differences.
Cool.
Yeah, no, thanks so much, Ali, for coming on and asking this, very, very personal questions. And we're very happy to kind of weigh in. I mean, let me kind of just talk a little bit more generally about it, obviously, because I don't have all your data in front of me. And there's a lot of, rigorous personalization that goes into a protocol or something like that. But I'll say there's at least 2 or 3 things to consider here. The first is that, there is this idea of cycle to cycle variation, right? So, sometimes you could just kind of have a group of eggs in which, for many reasons, they did not mature perfectly well, or they did not lead to a great group of embryos, or whatever it could be. And you do another round of IVF and you have pretty remarkably different outcomes, right? Because an N of one cycle is very limited. And after 2, 3 cycles, if we're getting the same thing again over and over and over, we're seeing, wow, these are really kind of like low quality eggs or very low fertilization or something like that, then you can say, okay, this is fair to come away from this as a conclusion that this is the general trend. The second thing is that there can sometimes be things in the background, minor things that can make a minor difference, right? So, and I think it's important not to overplay that, because there are books out there that say you got to turn your life upside down, get rid of every plastic thing in your house, and don't look at a blue screen ever again. And then you're going to suddenly have the golden eggs, right? And that's just unfortunately not true, really. I think they can make a minor difference, though, in kind of helping incrementally adjust things a little bit better. And so in our field, we're very interested in things that have incremental improvements. I mean, the amount of time that we just absolutely obsess about minor improvements in the lab to get a 1% better outcome for our patients is a testament to the fact that doing a 1% better thing for the eggs upstream can also be worthwhile. And then I think the third thing is this concept, again, of luck, right? And things that are out of our hands. And biology is not physics. We were actually just before the thing talking about the difference of reproductive biology versus physics, and the fact that you can have the same input in biology and have a very different output because there are so many variables in between. And I think when you're young, the range of these variables can go in your favor more often than not. And so I think those are some things to just consider when somebody comes to this and says, I have really poor egg quality, even though I'm really young. I think there are a range of things that we can do, but I won't get into the specifics of the details of protocols and things like that, because there's so much more nuance to that. So, but anyway, that's my longer spiel on that one.
No, thank you.
Ali, do you mind if I share with Dr. Sam and everyone what happened in your IVF cycle?
Yes, that's fine.
Yes. So with Ali, one of the things she did is she actually did an IVC cycle, which was a cycle where, we didn't make a lot of eggs, didn't work, and there was concerns about there could be, some other issues. So we did IVF. And this goes back to what I just said a little bit ago about how IVF is not just a treatment, but a test. Then we were able to learn things. And for example, there were quality issues with the eggs, fertilization issues. Of the multiple eggs we had, maybe 4 or 5, fertilized, and only one of them made it to the blastocyst. And it was a very good embryo, by the way. Is it okay if I let them know the outcome too?
Yeah, that's fine.
Yeah. So Ali actually did get pregnant, but again, I always say there's no participation trophies in the pregnancy. It's either I have a baby or that's it. So it didn't help to get that. But what that told us, we talked about the silver lining. I always try to look at everything and say, what did we get from it, right? And so the silver lining is, okay, we know your uterus can work, right? That baby implanted. You cannot have HCG in your body unless you're pregnant, or if someone's injecting you with HCG and you don't know it. But I think you would know that if that's happening. Going to what Dr. Salem said, I did a podcast about this one time about we tend to want everything to change. We really think like, oh, if I take this ball and let go of it, it's going to fall to the ground. So next time if I let go, it'll go up. And then it falls down. We go, well, I'm not going to keep doing it over and over because I'm going to get the same results. But as Dr. Salem said, the conditions stay the same. But that doesn't work in the human body. And so I liken it more to someone taking a car to the mechanic. If you take a car to the mechanic, it's making a sound, and you get it back and the sound's gone, but 2 weeks later it comes back, you're not going to be like, I'm not taking the mechanic again because I know if it's the same thing, I drop it off, it's going to happen again. No, because something will happen. You may not know what's happening, but something will happen different, right? They're going to do some different diagnostics. Well, that's also true when we do a transfer. That's also true when we do a retrieval. Your body could be doing things different. Your uterus can be different. Everything can be different. So even though it feels like you're doing the exact same thing, you're not. And so when you're looking at cycles, I liked this recently about making spaghetti in one of my podcasts. And I said, when you're trying to come up with a recipe, you don't go and make a recipe and you try it and you go, I'm starting with everything new again. No, you make adjustments. You say, okay, those noodles didn't work so well. I'm going to try a different noodle. Mm-hmm. Or I put a little too much salt. I'm going to back off on a little bit. And so for your case, what I can share with other people is that don't look at a failure as like it's never going to work. But look at and go, where can we make those adjustments? And in all fairness, Dr. Salem, he doesn't know everything. It's just a little hard. But like, for example, growth hormone might be beneficial in this situation because you didn't get great blastulation rates, right? So we look at all those different factors and then we make those adjustments. And that's, really what IVF allows us to do, to truly know what's going on and then make those small adjustments. And I have no doubt you are going to be having success. I know it may not be, can't tell you which time, but you are not the type of person that won't ever happen for. And like I said, we had that fortunate silver lining too, and that should give you a little bit of that hope. So
absolutely. Thank you guys so much.
Yeah, absolutely. Have a great night. We'll get Ari back here in a second. Anything to add to that, Dr. Salem? Anything to add on that?
Yeah, no, I think that's just a great point. I think sometimes, this idea of, well, what if I don't change everything for my next IVF protocol, wouldn't that just be crazy? Because we're just trying the same thing again. And, I think the short answer to that is that, no, that's not crazy. I mean, sometimes you can try the same thing again if you have enough parameters there that look encouraging, and you might have a very different outcome. You honestly very oftentimes do. There was one quick study I just want to mention that came out of UCSF, I believe, last year, where they looked back at changing the protocols for the same patient that had kind of previously failed the cycle versus keeping the exact same protocol. And remarkably, they didn't find that there was a change in success rates. Again, right. There's many things with this kind of a study. We shouldn't just take that as the end all be all. But I thought it was interesting that what they're getting at, and what my take home message was if you do the same thing again, even if you previously failed an IVF cycle, it can very well be the right decision.
Yeah. And the preface on that, I think the important part, what you're saying is that if the cycle is good, obviously if the cycle is bad, right. Meaning like, let's say you give a protocol and you realize you understim someone, obviously making adjustments to higher will be better. But I think you're right. Like the thing we don't think of is we think they're all related. I had a patient the other day who we went and, she did a transfer. She got pregnant. She had a subcoronary hemorrhage and lost the pregnancy. And she was like, I want to go back to the original way I did a transfer years ago. And I asked her why. I said, and she said, well, because, I'm worried that the protocol caused the miscarriage. And I explained, oh no, that's not, the protocol has nothing to do with that. And one of the things I said to her was, well, if you were in a car accident and you lost the pregnancy, would you still want to do that other protocol? And she's like, no, I'd do the same one again. And I said, and that's the thing where we go back to that uterus. We don't know what's going on inside. It's so easy to feel like it's doing the same thing, but what's happening afterwards. And so back to that point, I agree 100% that, this stuff is hard. I mean, it's always scary doing the same thing. It's part of us wanting to do something different. So it's a tough thing, but always talk to your doctor and ask them like, but will it benefit me to change anything? Don't just feel you want to change the change. So I'll get Ari back on. Sorry, I didn't mean to kick you off, Ari. I just thought, didn't want to make you sit there staring at us.
Okay, we have 3 questions in order. Looks like we have like 20 minutes here. So we have one for, I think it's Venetia. Sorry if I butchered that. Her question is, she didn't want to come on the live, so I'm just going to read it from the chat. It says, considering the rise of autism and other developmental challenges, is there any recommended supplements for us in the IVF journey since the PGT does not test for some of those abnormalities?
Yeah. Maybe I'll just kind of kick this one off really quickly. I mean, I think that this is a question we're seeing more and more and more of these days. And I think I want to kind of take it one step back really quickly just to highlight this very important point, which is that PGTA absolutely does not test for every genetic thing that can happen, such as autism. It's testing for chromosomal aneuploidies, whole chromosomes that are extra or missing. And really, we're looking at that to minimize the risk of an embryo not taking, not making sure that a future child doesn't have autism or, is going to score a perfect SAT score or going to go to Harvard or something. Now, getting back to your more focused question, though, about supplements and autism, unfortunately, there's no good research that shows that this supplement can, minimize the risk of autism. And autism is a disorder or a condition that has many genes involved. The environment is highly implicated in it. There's many things that go into developing autism. And then on the tail end of that, we are getting better as a medical field at diagnosing autism and really supporting children that have autism to better develop. And so we're probably picking up a lot more autism is what I'm getting at. There's also some relationships with autism and increasing paternal age. And so we see that especially beyond a paternal age of 50, we see kind of increasing, autism rates. The minority of kids that are born to fathers over the age of 50 are going to have autism. It's still a very small number. But at the end of the day, there's no way that we can, across the board say we can prevent it. I know there are many ongoing studies looking at how can we predict this or how can we interfere a little earlier, but there's nothing in real time. There's no game time type of intervention at this point yet. But Dr. Amos, I don't know. There's a lot more on this subject, so I'll let you take it away.
Yeah, I don't know if I have much more to add. I mean, you summed it up correctly. I mean, right now there's not a clear correlation, with IVF and autism, but there are some associations with, older age, even actually just having more money. In the past, there used to be people who are more wealthy have more kids that are autistic, and so people who did IVF were usually wealthy, and so there was this connection, and then later that was found to not be there. I think the thing I'm just going to add, just one part, is it's important to know that we are always worried about this. So there's a thing, the CDC requires us to tell about things that are going on after IVF. So one of the things we do is after you deliver, we come back and ask you for information. And there are studies constantly being done looking at these things. I mean, this is something that IVF is not going away. Reproductive medicine is only going to get bigger and bigger because we're, thinking beyond this. I mean, there's going to be days where ridding diseases, it's gonna be like Gattaca someday. Do you want your kid to have blue eyes or stuff? And so, looking at this and making sure it's safe for your kids is something that is very important. So, if anything, at least it's not like we're all just going, "Oh, let's just make babies." We're looking at this stuff all the time, and the minute we find out that those things are there, we're going to let you know, and you'll hear about it. And so, unfortunately, right now, autism is a really tough thing. It's not easy to know who's going to be affected, and it's even, as he said, diagnosing has increased now, and so we're seeing a higher amount. But are we seeing more, or are we just seeing more diagnoses? But in the end, I agree with everything you said. Is exactly what I would say. I just think the most important part is we are looking at those things all the time, and at this time, unfortunately, no one can give you a clear answer of yes, you're going to have it. It's just you have a higher risk if you're in these associated groups. So let's get Ari back on, see if we have another question here.
Okay, question from Shauna via Instagram, wanting to know if in my case, should we choose to transfer 1 or 2 eggs? And if we get that far, and then she also asked if she's taking the appropriate supplements for IVF. So I'm guessing she wants to know what are the appropriate supplements, and is there more of a chance if she transfers 1 versus 2 embryos?
So I'll do this one. So you start the last one. If you ask a doctor, every time we're going to tell you 1 embryo is the safest thing to do. Unfortunately, you don't hear about these things, but when people have things like triplets, there are bad things that happen. And the reason you don't hear about them is no one wants to tell a story about how they had 3 babies and they lost them all. And so you only hear about the good news. When you hear about 4 babies, the reason why it's such news is it just doesn't ever happen. Most of the time the news is horrible. So from a doctor perspective, it's always going to be 1 embryo at a time. That's always going to be the safest. I also mentioned earlier, if you heard, I was talking about if you put 2 embryos back and that's all you have, you actually have a higher cumulative pregnancy rate putting 1 back at a time, cumulatively, than you would putting 2 back at the same time. So if you want the highest chance, again, 1 at a time. But there's obviously financial constraints where you have to pay for 2 transfers now. And there are some clinics who still allow 2 embryos. We're one of them as well. But only in situations. There are situations it's not safe to put back 2 embryos. So when it comes to the question of how many embryos should you put back, it's always going to be 1 what we're going to recommend. But obviously, this is where you have a discussion with your doctor, what's safe for you, how many embryos you have. And even just things like, for example, I had a patient one time who their partner was handicapped. And, I said to them, listen, you can definitely do 2, but being a father of 2 sets of twins, I mean, it was hard, and I'm not handicapped, and it was very difficult. And so I can't even imagine if just one person had to do everything. And so those are all the considerations that have to be in. But in the end, everyone's always going to tell you 1. And there's even a big movement. There's many clinics who won't even do more than 1 embryo anymore. And there's actually even a push on our clinic to have to start doing that because for insurances to cover us, they're basically going to start saying, if you don't put back only 1, we're not going to let you be on insurance. So unfortunately, that is one way it's going. With regards to the supplements, I'm going to let Dr. Salem answer that one a little bit more, but I can tell you my view is that there's only a few out there that really benefit, and most stuff out there is just Facebook stuff that you're reading, and especially for men, there was a recent studies coming out showing there's probably not much benefit for men to taking supplements. But I'll let you answer that one, though, Sim. I don't want to take all the spotlight here.
No, not at all. And just to clarify, Dr. Amos, I mean, I think, correct me if I'm wrong, but you were talking about PGTA tested embryos, the recommendation always.
Oh, yes. I apologize. Thank you so much. No. Yes, I'm so used to that question coming with that. So yes, you are right. The ASRM criteria are a little bit different when they're not tested and depending on your age and things like that. So, but obviously we need to know that information. But yes, I was talking about PGTA embryos 1 at a time. So.
Yep. I mean, I think in the background, again, there's been a very big push, of course, recently to do PGTA tested embryos, but there are still people who select for one of many reasons not to do that. That's another conversation, of course, but there is always the option to transfer, more than one embryo depending on the age, because now you're getting back into this realm of, just trying to get a pregnancy started. And there's all kinds of things about, the financial implications, accessibility, et cetera, et cetera. And Dr. Amos, I totally agree with everything that you said there, with regards to all that. Now, jumping back over to supplements, supplements is a tricky thing, because I think that there's a couple different parts here. I think when people are looking at supplements, what they're really telling me is, hey, Dr. Salem, I want to do everything that I can to make this cycle work. I don't want to mess it up on my end. So what can I do to make this work? And so supplements are, in my opinion, part of a larger package of lifestyle. People who want to seek complementary therapies as well, I highly encourage them to do that. Emotional and psychological support. This is a very stressful thing to go through. And of course, healthy diet, exercise, healthy sleep. This is all kind of part of a continuum of things that will set you up for success to go through IVF. And a lot of that you have control over. Now, supplements are tricky for one of many reasons. So we're doctors, we're evidence-based doctors. We're rigorous about looking at research. And what supplements have not done very well is rigorous research. And so it's hard to do rigorous research on supplements for many reasons, but what you would really need is a good randomized controlled trial showing if this group of people took the supplement and this group didn't, and they did the exact same treatment, who did better, that kind of a thing. And the reality is that's really, really expensive to do that. We don't have that level of data. So we have the next echelon of data, which is kind of observational data. Some things look okay. Some things certainly look like they don't have any harm. Probably the biggest harm is the fact that you're swallowing a cocktail of, pills every day and spending, $150 a month doing that. And some of them may have benefit. The obvious ones that come to mind that may have benefit are myo-inositol for PCOS, coenzyme Q10, and other antioxidants for, diminished ovarian reserve or women who are a little bit older. And for men, I agree. I think the research isn't panning out so well on the supplements thing right now, but that's kind of my 2 cents on it. And I think I hope more research will come out, giving us some direction on this one.
What do you think about DHEA?
Yeah, definitely. So DHEA, I was just using this with one of my patients earlier today. There's 2 things that I think that are interesting here. There's a little bit of research around this with regards to women with diminished ovarian reserve, advanced maternal age, and kind of helping potentiate the effects of an IVF cycle, making it a little bit better. But I do think it's important to monitor those levels. I think if we use it, we should try to use it accurately and precisely, and to make sure that they're in the therapeutic range. So it takes a little bit more monitoring. It's a little clunkier, but I don't know. What do you think?
Yeah, it's interesting you said that, because I definitely have a little bit of a different view on that. When you think of DHEA, and just so people understand what's behind that, the thought process is that women who have polycystic ovarian syndrome usually have elevated male hormones, and they usually have more follicles. And so the thought was, hey, if we give this milieu to this woman for 3 months and she has elevated testosterone, she might have more antral follicles that we can use then to grow. And so, there's actually a book, it starts with the egg. And, I think it's a great book for people who want to read it. I think that there's some really good stuff in it, but there's things in there I think are actually a little bit concerning. And one of the things that I disagree with that book, and again, you and I would probably have tons of talks about this, is the goal of the DHEA is to be super physiological, right? I mean, women who have PCOS have super physiological levels of testosterone that cause them to get things like hair in their face, hair in their breasts, hair in their abdomen. So I can't see a way where a certain number needs to be made. I think you have to have a baseline, you could say, now we get to that super physiological level. So someone who has, let's say, 500, you go, that's too much. Well, yeah, but what if they normally sit 300, 400, and someone who starts at 100, I wouldn't want to give them the 500. Otherwise, they're going to start getting dark hairs and be mad at me and say, why'd you give me these dark hairs, Dr. Amos? But That's just one thing I always felt like you need to get that super physiological level. And so even in that book that talks about only getting to a certain number, but everyone needs, I think, a different number. The one thing I wanted to ask you now, kind of a question going back on that is, and where I think there's some dangers of that book is, I feel like people tend to blame themselves and think that they're causing a lot of the problems. And it's a very reasonable thing to think, because when you really think about it, I mean, if your heart goes bad, right, you probably were unhealthy, right? If you have diabetes, you might have a poor diet or something. So we're used to normally our organs failing or something going wrong because of things we do. But what's interesting is that it doesn't work that way when it comes to really the sexual organs. Not saying completely, there's obviously points where it can affect, but like when my sperm was bad, I was in bodybuilding. I mean, I was literally in the gym 4 hours a day. I was eating tuna from a can. I was the healthiest I've ever been in my life. Sperm was horrible.
Yeah.
Same thing with women. I have athletes who come in and they have bad egg quality. And so sometimes where I get worried with these supplements is that I tell people, listen, if it can't hurt you, I don't care. It's not going to harm you. Take it. I just don't want doing something that's going to harm them. But I think it's really important to understand there's only so much benefit. There's a point where they're not going to make someone who has eggs, as we talked about the patient saying, a 40-year-old egg, all of a sudden become 28 now. It's not going to happen.
Right.
And that's the important part, I think, is that all these things are great to do, and you feel like you're doing stuff, and it does have those little benefits. But in the end, don't think you didn't work hard enough. Don't think you didn't take enough supplements. If it doesn't work, it's usually other things. And that's why crack addicts have babies. And that's why sometimes healthy people don't. It's not just based off of the environment.
Yeah.
It's some, but not that as much as people think. What do you think on that?
No, I think it's like totally a great point. And like, I think the other end of that spectrum that I've seen sometimes that worries me is that sometimes people get really anxious about the supplements. Oh, I forgot my whatever supplement this morning, or I haven't been on the supplements for 3 months yet. I don't want to go through a treatment cycle or something of that kind. And it can, kind of lead to a lot of anxiety around it. And I think that's kind of where the pendulum swings in the other direction and can probably do more harm than good. And again, you have to remember, like, behind supplements, behind all these things, like, there is unfortunately an industry which is trying to sell the supplement. Yeah. So, and in theory, what good medicine is supposed to do is say, we have data for this, we don't have data for this.
My favorite example of that is prenatal vitamins. When they have DHA in them, everyone thinks they need to take them. Like, it really is not going to help now. It's when you get pregnant it's going to help. But people spend more on the one because it's better. And in reality, the DHA, you either could take some fish oil later or, wait till you're pregnant to start that one. We'll get Ari back on here, see if we got another question. I know we're getting near the end here. So,
yes, we have a question from Teresa and Richard. They said, how much does low mobility affect the process of getting pregnant?
Yeah. So we're talking about low motility for sperm. So this is one of the parameters that we look at on a semen analysis. So whenever we do a semen analysis, we're looking at all kinds of things: the shape of the sperm, how fast the sperm is moving, if it's moving, what proportion of the sperm is moving. And the motility is one of these factors. And motility is definitely associated with the underlying fertility. So kind of having a very, very, very low motility can absolutely impact the chance of getting pregnant. Now, again, there's many ways to look at this, and there are many other parameters around this. So one way to answer this is that low motility on its own is not an absolute you will never get pregnant issue. And the flip side of it is that, there isn't just one quick fix for low motility. Low motility can come from a whole variety of things. I mean, it can be lifestyle things, like, for example, turns out, smoking a lot of cannabis can lead to low motility, right? It can be something you were born with. It can be a whole variety of things. And there isn't always, at the same time, there's not always one quick fix. So how much does it affect getting pregnant? I would say it certainly affects the natural chance of getting pregnant. There are many interventions that can help kind of alleviate that chance, to kind of give sperm a head start, such as, IUI, or if the motility is very severe, those are cases where maybe we need to consider IVF. But that's just kind of answering in a little bit of a general way, but I'm sure you have another take on it too. So I don't know, take it away.
I think one of the interesting things is that, as you mentioned, there's a lot of parameters to it, right? So when you hear motility, if I was in a doctor and was in this field, I'd be like, it's how the sperm moves. What's funny is the word motility has nothing even to do with really how the sperm's moving. It's really asking, are they alive or dead? So when someone has 20% motility, it means 80% of their sperm is dead on ejaculation. That's why you can have 1 billion sperm. You're like, you make more sperm than even Brad Pitt could make. Okay. You're making the most sperm in the world. And yet, if only 20% are moving, that's going to make it hard for them to get into the cervix to be able to get pregnant. So even though you have plenty of sperm behind it. And that's because very little sperm actually gets into the uterus. And so all that sperm kind of blocks it. We call it a colligative property of something. When it's not a property of the sperm itself, it's just a property of when you have a lot of things not moving, molecules, then it can affect it. Just like kind of like salt and water when you're trying to freeze or boil. There's a thing called progressive motility. And that one is actually how they move. So let's say you had 100% motility. You're just standing tall, chest out. I got 100% motility. Everything's moving. They're the best. But your progressive motility is very poor. And usually that's in the grading systems, like 4, 3, 2, or 1. 4 being like the best it can be, Michael Phelps, Katie Ledecky. But the ones that are lower, like a 1, it means your sperm is just twitching. And so that question that you asked is a very good question. And the answer that Dr. Salem gives is perfect. Yes, it absolutely can affect, but those parameters make a difference. And I can't tell you how many times I've seen patients and they're like, oh no, the doctor said it's good. I'm like, I don't care. I'm looking at the report, because it's those parameters that make a big difference. You can have 80% motility, but if you got a grade of only 1 or 2, those sperm aren't going to be doing well. My favorite, this is actually a funny story. So one time I had this patient, I'm sorry, I don't want to take up a bunch of time, but this is a great story. I'm doing the HSG on there. And I usually will kind of talk to them about, their case, what's going on. She's telling me, I'm like, God, it really sounds like a male factor problem. She's like, oh no, definitely not. My husband, everything's good. I'm really shocked. Everything's good on her. Tubes are open. And I said, are you sure that it's, like she goes, oh yeah, they said everything was good. I was like, okay. Anything in his history I need to know about? I mean, like, and she's like, oh, well, he did have testicular cancer. I'm like, excuse me? And she's like, oh yeah, he had testicular cancer. I'm like, wait, was the semen analysis after like therapy? And she's like, yeah, he had chemotherapy and stuff. I'm like, interesting. So I'm like, I'm really interested. I said, why don't you get me that semen analysis? I got the semen analysis I looked at, and the numbers were amazing. I mean, I thought it was Brad Pitt at first because it was so good, right? But then I looked at motility, and this is the one time motility can prevent you from getting pregnant. It was 0. Not a single sperm was alive. And so it just points to that thing that you really have to look at the details. And just because if you have a doctor telling you that your semen analysis is normal, make sure it's a fertility doctor. Because if it's an OBGYN, which this one did, and nothing against them, they don't have the training we do, they're going to look at it and think things are good or not. So always make sure your semen analysis are read by a fertility doctor. So anyways, we'll let Ari come back and we'll answer more questions. I know we have a couple people will try to get you. We may not be able to tonight, but we will be back and we'll post those shows when those are coming. We'll get you on that time.
Okay. I have one question from Facebook. It says, thoughts on our ovarian rejuvenation and PRP?
I was actually going to have us hold off on this one. I feel bad doing that, but I think this would actually be a great opening for the next show, like really a pros and cons, because that's a really, we were talking about this beforehand, and I think that would be a really good 10-minute discussion where you and I can go over the pros and cons, take a different stance. You take the pros, I take the cons. I'd hate to just mess it up right now. I really think I saw that question. I thought, let's hold off on that one. We'll do that at the next show as an opening monologue.
I like that. Let's do that.
The two of us.
All
right. Anyone? Well, are we going to try Candace again? I feel horrible. Candace has been there the whole time, and her audio wasn't working, and
let's try.
She was the first to be on here. Candace, is it working now?
Can you hear me? Am I
I
coming in
can.
clear?
We can.
You know what? It's okay. I enjoyed the conversation. It was all very helpful for me. A lot of the questions that I had would have been the questions that were asked were questions I had anyway. So all good. This was a great show. Thank you.
Yeah. Is there anything you want us to like go over? Any other questions, or maybe even expand on some of our answers of the questions that we were answering?
So I did one of the questions about multiple births with an embryo. And so genetically, if someone's predisposed to having twins, and maybe it's an out wives' tale type situation, but if you're predisposed, or you're, I guess, familial predisposed to have twins or multiple births, putting in one embryo, does that have an effect on if you do have, again, identical twins? So that was one of the questions I had. That was kind of an expansion on someone else's, the Mutters.
Yeah. Go for this one, Dr. Salem. I mean, this you see us both smiling for a reason.
Well, I do love this question. I mean, first of all, this is very interesting because what we know from global kind of data is that there is actually a difference between certain groups of people and the natural chance of having twins. But what we're talking about there are not identical twins, right? We're talking, about twins that come from two different eggs, two different sperms. And if you go through IVF and you put one embryo in, it has a very roughly 1% chance of splitting. And that is not related to your own family history of having twins.
Got it.
Yeah. And so that's why I was smiling too, is that we tend to think of twins running in families when they're identical, but actually when that happens, it's literally just chance. And but when you have twins, fraternal twins, as he was saying, 2 eggs being released, it means that woman releases 2 eggs.
Got it.
And that's why they're about fraternal twins. And it runs on the female side. So there's no man making 2 sperm that are making it work. So it runs on the female side. And there's actually there's a country in Africa where I believe, is it Nigeria? Is it? I can't remember. Do you remember, Dr. Salem? Was it Nigeria, right? That where I think they said that because of the high yam or that they eat, that phytoestrogens that they get from the food, causing them to release more eggs, and they have one of the highest twin rates in the world, but fraternal, not identical. And while we're on this topic, and thank you, Candace, for that question, I was gonna pivot off with Dr. Salem here. While we're on this question, I think one of the things that when people ask about putting back 2 embryos when they're PGTA tested, one of the concerns is if even you look at natural, not in IVF, but naturally, it's about 1 in 240 chance of an egg splitting. Obviously, as you pointed out, IVF slightly a little higher. We think it's something to do with ICSI or something that does it, but if you put 2 back, now you're talking about 2 over that denominator. So if it's 1 over 100, you're talking about 1%. You now have 2 over 100. Now you're at 2%. And that's a really big deal. That's a 2% risk of triplets, not twins, of triplets at that point. So it's a pretty, like I said, it goes up pretty high. And so important to, to talk about. I know we're getting near the end here. Ari, you have anyone, maybe a simple question or stuff? I see couple people there. I'm sorry if we don't get to you, but we want our wives not to divorce us, so we want to make sure that we keep this to a certain amount of time.
I don't see any more on this end in our chat.
Well,
I just see I'll eat more yams.
I saw there was a couple other people, Rochelle, Lakeisha, and Crystal. Are any of them wanting to come on? We'll do one more guest. I think we'll kind of end it there. And then
we have Crystal. You want to give a thumbs up if you want to come on?
Perfect.
Thumbs up. Okay, we're adding Crystal.
Hi, Crystal. Thanks for joining us.
Oh, you're welcome. I wanted to come on to say hello and that I had a question about mosaic. What do you guys think about mosaic? Because I know I'm mosaic and I'm Turner syndrome, so I just thought I'd expose myself. And
Crystal, do you mind if I share a little bit about that with everyone?
Share away. Yeah, share away.
So Dr. Salem, so she does have mosaic Turners. And so obviously, if people don't understand what mosaic means, it means where some of your DNA is one way and some of your DNA is a different way. And some cells can be normal, some cells can be abnormal. It can even be throughout. So in her situation, if you have Turner syndrome can lead to early failure of the ovaries. And when people have mosaic, they can get a little further in life than they can when people are just pure Turners. But anyways, I know Crystal very well. I've known her a long time. She's probably one of our biggest fans. She's so sweet and is a great person. And we're obviously, I can tell you we have some good news coming so far. So we're really excited about this cycle. But Dr. Sam, what do you think about mosaic? And Crystal, I know you're talking about mosaic and you. It might be a good part. We'll tangent off about mosaic embryos afterwards. But anything you have to add, Dr. Sam, about Crystal's case or anything like that?
Yeah, I mean, just very quickly, like this is one of the super exciting things in our field about being able to make the most of a person's reproductive health span, right, Crystal? So like the idea is maybe there was a time where you kind of may have missed your window or something, or people who have a mosaic condition like mosaic Turners may miss their window. And here we're able to kind of really optimize that period of reproductive health span and potentially, of course, use genetic technology, et cetera, to make sure that the embryo that we're passing on is okay. There's, of course, always a lot of things, and I know, every fertility doctor is kind of all over it, but with any patient, you have to kind of personalize both the, trying to get pregnant part and the making sure they're healthy to be pregnant part. And so that's obviously a conversation for another day. But I wanted to touch really quickly on one thing, which is under this topic of mosaicism and mosaic embryos, because I think this is kind of, maybe it's a little tangential to it, but it's a very interesting part of what's happening in our field over the last few years, which is that a mosaic embryo is one that we're not 100% sure it's abnormal. And let's say not 100% sure that it is normal. It's somewhere in the gray zone. It used to be thought, I guess, that you couldn't transfer these at all because they would never lead to a healthy baby. And fortunately, there's been data coming out that there's a group of those embryos that you can transfer. They still have much lower success rates, but in an effort to not lose that last embryo kind of thing, I think there's a world that's very fair where we're transferring, mosaic embryos. There's a lot of things that you have to take into consideration when you do that. There's a lot of contingencies, but just thought I'd touch on that since you had mentioned it, Crystal.
Yeah. And
Definitely.
thanks so much for your question, Crystal.
You're welcome. Thank you.
Oh, I'm so sorry. I didn't mean to cut you off there. It's interesting about mosaicism because, and I think this would be a great dialogue for the beginning of one of our shows, is there was a big fear that people are getting pregnant with abnormal embryos. There's a guy, New Hope Fertility in New York, put out that, hey, he put back 20-something embryos that were all abnormal, and people were getting pregnant, and then people were getting afraid about this. And what wasn't truthful about it was most of them were either mosaic embryos, and mosaic embryos, as you said, are not abnormal. I mean, they technically, at this point, we have to call them normal. And what would be great to kind of explain to people is what the normalization is that when you take data and you normalize it, there are things that could be, that can basically, it can skew the data a little bit. And so my point with mosaicism, and I was trying to make and fumbling over here, is it's both normal, abnormal, possibly mosaic, but we know mosaics don't occur at that high of a rate naturally. So what we're seeing in fertility is not true mosaicism. That's how we know a lot of them are probably either really abnormal or normal. And like I said, I think it would be a really good topic for us to start with sometime, because I think it's enabling, and then eventually even go into partial deletions and things like that. So
I like it.
Well, I want to thank everyone. I mean, I think this will probably be a good time. We've been out for about an hour, 15 minutes. And, we don't have a set time, but I only eat once a day. And so I haven't ate yet today. So I'm going to be eating soon. But I want to thank everyone who was on here. If we weren't able to get you, I'm sorry, but we will get you next time. Maybe even just send us a message and we'll try to make sure to put you first. We will announce the next show here on the website. So always just go to spermmeetsegg.com, and then we're going to try to put links to the show in case you missed it to be able to watch it on a record thing. But again, anything you got to add, Dr. Salem?
No, this was so much fun. I really look forward to having more people come and join us, ask questions. And I look forward to the next one already.
Yeah, one thing we talked about is even getting guests on here. So we're thinking about bringing some, different reps from different companies, the things that you use, even other doctors we know. And, really would love to just allow the community to have access to these things that you usually don't. Usually you're just seeing whatever we say. Now you get access to. And that's really the whole point here, is to bring access to our patients, and not just our patients, any patients, to be able to ask questions. So
yeah.
Hope you guys enjoyed it. Hope you have a great night. And wish you all the best.
Take care. Good night.
Good night.